Hello, NephU community, and welcome to the Hot Topics in Nephrology podcast. I'm Jeff Lockwood with the NephU medical team, here with our kidney news extraordinaire, nephrology writer and editor, Mark Newman. Every month, Mark keeps us up to date on the latest hot topics in nephrology. Mark, how are we doing today?
Well, it's a little warm in Arizona. As you might imagine, our summer is the time of year when you want to leave, of course. So I think it's going to be 116 by the end of the week. That's warm.
Well, I tell you what, I was feeling a little bit hot yesterday up in Michigan at around 88 degrees, so I do not even want to try 116. You can keep it.
It's the dry heat.
Yeah, that's what they all say in the desert. So today, we've got a few topics to touch on, so I think we should jump right on in. So we will take a quick dive into the results of two clinical papers published in the last couple of months, and then Mark will give us a summary of the 2-year results from the Kidney Care Choices model released in May. The KCC model is a demonstration launched in 2022 by CMS focused on improving kidney care for patients with late-stage chronic kidney disease. So Mark, what do you have for us?
Thanks, Jeff. There have been a couple of interesting papers published recently dealing with kidney care. The first is one from Kidney Medicine looking at the quality of care provided to patients in a dialysis clinic who may have different types of insurance, namely Medicare versus a commercial or private health plan. In the study that looked at patients in over 7,000 U.S. dialysis facilities, researchers at Baylor College of Medicine found that shifting coverage from commercial to Medicare plans could negatively impact quality of care, particularly mortality.
And we have known for years that commercial plans reimburse at a higher rate for dialysis than Medicare. But how can patients sitting side by side in a dialysis clinic be treated at different levels of quality?
It's a good question. So I posed that to Kevin Erickson, an associate professor of medicine and nephrology at Baylor, and one of the authors on the paper. In an email, he told me, quote, "We conducted the analysis at the level of the dialysis facility. So our focus was on outcomes at facilities with more versus less private insurance." Along the lines of your intuition, he said, the outcomes either included all patients at a facility or patients with Medicare, with the assumption that all patients at a facility receive similar care, which is what we would expect. Our idea was that facilities with more private insurance have more resources to devote towards improving quality for all of their patients, he wrote. So, in other words, dialysis clinics that have a higher percentage of patients on a commercial health plan did better in terms of mortality, but so did everybody else in the clinic because it paid for additional resources for all patients. One caveat to the study is that the researchers did not look at other factors that might influence mortality, including the standardized fistula rate, long-term catheter care, the standardized hospitalization ratio, standardized transfusion rate, dialysis adequacy, and patient satisfaction. Quote, "There were non-significant trends toward fewer long-term catheters and fewer hospitalizations in facilities that had more private insurance," Dr. Erickson told me. "Perhaps with a larger study sample, these mediators of mortality will become significant." Those points are significant, Jeff, I think, because it suggests that facilities that have more commercial insurance may be looking at those indicators that can lead to mortality, as mentioned in this quote.
Right. And that means there is a silver lining for some patients who have others with commercial insurance in their midst.
So let's talk more about the impact of social determinants of health on outcomes. Researchers from the Weill Cornell Medicine in New York looked at the results of the ESRD treatment choices model, a predecessor to the kidney care choices model we will cover in a few minutes, to determine if there were in fact ways to incentivize greater use of home dialysis and transplantation. As we have mentioned to NephU listeners before, the ETC model was canceled by CMS earlier this year after finding little change in growth for home dialysis and transplantation, the two outcomes targeted by the agency with financial incentives. The rationale was that these are both lower cost therapies than in center hemodialysis and offer patients better outcomes as well. When those results don't come to fruition, what the Cornell researchers did assert in this study, published in JAMA, was that dialysis centers that had patients with certain characteristics, including low income, a higher population of Black patients, and were nonprofit facilities, had a higher likelihood of receiving financial penalties through the ETC demonstration because they did not meet performance measures. However, once stratified benchmarks were added to level the playing field, so to speak, penalties for those independent centers were closer to facilities without those characteristics. The benchmarks were implemented in the ETC model in 2022 when groups of dialysis facilities with higher versus lower proportions of patients eligible for both Medicare and Medicaid, or low income subsidy recipients, are graded based on those different benchmarks. Overall, ESRD incentives, quote, were successful in mitigating financial penalties to dialysis facilities serving more low income patients. One of the authors of the paper told the healthcare news service Helio, this may be a promising policy strategy to ensure that safety net providers are equipped with adequate resources to optimally serve their patients. I think that makes sense, Jeff. Provide additional resources to those dialysis clinics in need, and you will see their outcomes improve along with it.
So it's kind of like in hockey when a player's in the sin bin because of a penalty. The other team has a shot to add a goal. Once penalty's over, the player returns to make things even again.
Exactly. Now, this is a discussion about the ETC model, is a great segue into discussing the results from year 2 of the Kidney Care Choices model. Ironically, the ETC model also went through 2 years of results and was summarily shut down. Would the KCC model meet the same fate?
Well, I think the good news in the first year results from the KCC model that we reported on previously during one of our NephU podcasts showed some promising results, but Medicare didn't save any money. So, what did we see after year 2, Mark?
Well, more of the same. But the good news from the report by the Lewin Group is that the benchmark set by CMS and the providers showed much stronger improvement in year 2. Still, no real savings for Medicare short term. In fact, the agency paid $304 million more to physicians and value based companies in the KCC model during the second year.
What areas did we see the most improvement?
I'll review that in a minute, but I wanted to remind our listeners what the Kidney Care Choices model is about. Preventive care, i.e., treating patients in CKD stages 3 and 4, and even into 5, to help them slow down the disease or at least help patients prepare for long term treatment. I think if CMS can rationalize the big picture, it means things like the optimal starts, more referrals for transplantation, and more patients who choose a home therapy. These are all outcomes we saw in the current second year report, are indications that patients with kidney disease have a better chance at leading a normal life. So, with that preamble, here are some of the improvements seen in year 2. 1. Optimal starts were up by 31% compared to pre KCC model levels. 2. A 29% drop in the number of patients starting dialysis with a central venous catheter. 3. An increase in preemptive waitlisting, which is waitlisting prior to start of dialysis, by 40%. 4. An increase in actual preemptive transplants by 69%. Of that group, there was a 22% increase in living donor transplants. 5. An increase in the rate of home dialysis by 10%, and a decrease for in-center dialysis use by 1%. And lastly, an increase in home dialysis training by 22%, which is an indicator that more patients, likely in year 3 of this demonstration, will be going home. Patients with optimal starts are also those who have been referred to a nephrologist in earlier stages of kidney disease. So having time to learn about modality options and getting a fistula or graft is a much better start than emergent dialysis. In many respects, That is the mission of the KCC model.
And those are all good things. So, how is Medicare reacting to the report?
Medicare, prior to the demonstration, had invested very little in this population. The ESRD program was exactly that: care for the patients with end stage renal disease, with little focus on pre-dialysis care. Now, clinicians are finding out that new drug therapies and more time to educate patients is helping to slow down CKD. That should pay off for Medicare in the long run. This demonstration now runs through 2028. CMS's Innovation Center recently got the green light to extend it an extra year. So that will hopefully mean that CMS is confident this approach to disease management has a fighting chance to become future policy in kidney care.
Well, the old saying is an ounce of prevention, which, finally seems like we're heading that direction for some of these kidney care patients. So that's great to see. I'm glad they're going to give it an extra year to further look into this. Well, Mark, thank you for joining us to discuss the quality of care differences among patients with different payers. I was actually expecting to hear some bigger care discrepancies, so glad to hear otherwise. And also, great updates on the ETC and leveling the playing field, or I guess ice rink, based on our previous analogy, and the KCC model. We're making progress a little bit at a time, and I guess, like everything else, we'll see how this works for another year. A big thank you to the NephU community for listening in. Be sure to like and subscribe to the NephU podcast on the hub of your choice. And I hope you all enjoyed the conversation. Be sure to join us next month so Mark can keep us up to date with the latest hot topics in nephrology.